100,000 in 2007, and number of AIDS deaths was about 4,000 in 2007. The thing with these estimates, it's probably an underestimate, considering that by the end of 2008, we were already seeing over 80,000 people living with HIV among reported cases alone. And if we all know how HIV is, how it has a strong underreporting component to it through non-clinical symptoms, through underreporting among marginalized and hidden populations, 80,000 will be at the minimum of our estimates. Okay, next. So I mentioned that the injecting drug users remain the key driver of the epidemic. But in recent years, we are seeing an increasing proportion of sexual transmission of HIV in the population, and with it comes an increasing proportion of women among infected. And I mentioned we saw the observed decline in reported cases. One argument about surveillance was because IDU was the initial key population, surveillance among the IDU population is very active through the rehab centers and through IDUs in the prison settings. But with this change in transmission dynamics, it is possible that we are still only focusing predominantly on the IDU population, and that's why we are seeing the trend, the declining trend in reported cases. So perhaps we are missing out in detecting a different subset of the population who are sexually transmitted, and that may explain the decline in reported cases. Next. The three lines is showing the number of cases by risk factors, and this illustrates what I was mentioning just now. The blue line is the decreasing trend in reported cases among IDUs. So of all reported cases, IDUs initially was about 70 to 80% of all reported cases, and now it's just under 60% or about 55%. The red line is the number of cases reported due to heterosexual transmission, and you can see the increasing trend. The line showing the MSM transmission is also believed to be a severe underreporting because surveillance among the MSM group is very lacking, and also there is not an active presence of the MSM population, so it's very much a hidden population, so we don't know much about the MSM group in Malaysia. Next, please. So this table shows the proportion of females among total reported cases over the years. So we started off with mainly male population, about 90% males in 2000. But in the most recent years, 2007 and 2008, we have increased from 3% up to 16% and now 19% females among reported cases. So that is also a trend that is being on our high red flag, I must say, in terms of how it is starting to spread beyond the injecting drug use population. Next. In terms of regional distribution, with the initial epidemic being among IDUs, the major cities where injecting drug users are more common are the cities where HIV prevalence is highly dominant. And this includes Kuala Lumpur, the capital city, as well as Johor and Pulau Pinang. But in the two states, Sabah and Sarawak, that is in the eastern side of Malaysia, the Borneo, Malaysia, these two show the lowest number of cases overall. But their epidemiology is quite different from the rest from peninsular Malaysia, where number of IDUs reported is extremely low, and most cases are actually through sexual transmission. Next, please. So if you look at all the different states in Malaysia, this is in order of highest notifiable rates. So basically how many cases notified per 1,000 population, 100,000 population. So the two at the bottommost, Sabah and Sarawak, are from the East Malaysia. They are the lowest reported notification rate. But as I mentioned, they have very different epidemiology through sexual transmission. The middle group, the light blue, the Kuala Lumpur, Kedah, Johor and Penang, are the more urban states. And these are where we think IDU and also a mix with heterosexual risk is high. But if you look at the top two most highest notifiable rates out of 100,000 population, the states of Kelantan and Terengganu are the two states at the northern east coast of Malaysia. And they are also the two most conservative and, I must say, rural states. So that is a cause of concern because not much attention has been paid to these two states, and yet they are showing the highest notification rates. The key things about these two states is they are predominantly fishing communities in these two states, and recent data from our needle and syringe exchange program sites there show that among the fishermen, the rate of injecting drug use is actually very high, and with it comes the rate of HIV prevalence. And this is something we need to explore further here in Malaysia. Next. So some numbers for the most at-risk populations. I mentioned IDUs. HIV prevalence is thought to be about 20%. Amongst men who have sex with men, female sex workers, and transgender populations, in Malaysia we call them maknya, which is equivalent to the warias in Indonesia. We have very little information about these three groups. Until recently, we don't really have good second-generation surveillance data. So what numbers we have for these are very crude estimates. We think it's about 5% prevalence among these three high-risk and hidden populations. Starting this year, Malaysia is initiating its second-generation surveillance. We are going to do an integrated bio-behavior surveillance among these key hidden populations. So we're looking at HIV prevalence as well as behavioral studies. Next, please. Other vulnerable populations that we need to look at and of concern would be the prison inmates, where again injecting drug use is high among prison inmates. Most of them are actually in prison due to drug-related offences. Among the migrant and mobile populations, as well as refugees and displaced populations, and some of these mobile populations are occupational related, like I mentioned, the fishermen in the East Coast. Youth and women are also vulnerable population, especially looking at the recent trend in the increased number of reported cases among women. And in terms of intervention in Malaysia, one of the key things that has been done in Malaysia is the coverage of antiretroviral treatment. Among the reported cases, those who are at advanced stage of HIV, about 50% are receiving antiretroviral therapy. And the Malaysian government, through the Ministry of Health, provides free treatment for Malaysian nationals for the first two treatment regimes. Therefore, cost for the patient is quite significantly reduced. The issue with the treatment provision, however, is that while the financial and the treatment provision is very good, accessibility is still an issue. So even if we do have provisions for treatment, those who come forward to receive this is still an issue. Some is because of maybe they are IDUs, therefore they don't stick to treatment very well. Some is a matter of distance to locations, and also the fact that a lot of the cases are among hidden populations who are not accessing public healthcare services. And we see a disproportionate number in terms of reported HIV cases among IDUs versus the number of IDUs who are actually accessing the antiretroviral therapies. Malaysia has good antenatal clinic screening, so 100% of pregnant women who attend government antenatal clinic are screened for HIV, and if found to be HIV positive, all of them are given treatment. They are all on ARV therapy. Among HIV patients, among TB patients who have also HIV, about 34% are on antiretroviral treatment. I mentioned just now the national strategy on harm reduction, and the two key programs that have been implemented are, first of all, the needle and syringe exchange program, and the second is the methadone maintenance therapy. And these were initiated in 2005 as a pilot, and now they have been expanded and aim to do a deeper coverage at the national level. Finally, general awareness programs are also in place, one of which is a youth-targeted program called ProStar, Program Sihat Tanpa AIDS, or in other words, Healthy Without AIDS program among the youth. Okay, key players in, next slide please. Key players in HIV intervention in Malaysia would be the Ministry of Health, the AIDS and STD Division, and the Malaysian AIDS Council. The AIDS Council in Malaysia works very much like the Philippines PNAC just now, and it is a council that manages 40 partner organizations scattered throughout the country. The Ministry of Health came up with a national strategic plan for HIV-AIDS for the year 2006 up to 2010. They are in the midst of doing a midterm review and also drafting the next session now. And through the national strategic plan, they have 6 key strategies, which is to reduce HIV among young people, among adults, among IDUs, reduce transmission from mother to child, reduce HIV among marginalized groups, as well as to increase survival and quality of life. The Malaysian AIDS Council itself also formulated recently their own strategic plan, and this plan of intervention and implementation is action based on clusters, where each cluster targets different key at-risk populations and programmatic aims. Okay, next. Finally, the key issues and challenges for Malaysia in terms of HIV/AIDS is that we do not know enough about our own epidemic at the moment. Prevalence data, behavioral data, and information about our key population at higher risk is still lacking, but the government, along with collaboration with the National AIDS Council, is working towards improving this. Hidden population is still an issue. There is also an issue of stigma and discrimination, which is tied up with the cultural and religious sensitivities of the country. Malaysia is mostly a conservative society, therefore talking about certain issues when dealing with HIV/AIDS can be difficult. There are some problems or issues with policies and laws and enforcement in the country. For example, the illegal nature of drug use and sex work, which sometimes can hamper intervention and prevention efforts. So with that, thank you from Malaysia.
Thank you, Dr. Razali. Now we move on to Indonesia.
Yeah, hello again.
Please.
Yeah, I want to present the country report from Indonesia. Yeah, this is the outline about the epidemiological data, about health education, prevention, care support and treatment, and a little bit about empowerment. Slide. So, as mentioned that in 2008, it's estimated around 270,000 cases in Indonesia. Women is around 24%, and mode of transmissions, more than 50% is also IDU, like Malaysia. Slide. I already present this diagram that's showing that growing new cases since 2004. Slide. And this the diagram, the 3 scenario, and we hope that we can achieve the lowest one if we could cover 80% of the risky behavior and the effectivity around 60%. We hope that in 2020 we will only have 600,000 of HIV cases in Indonesia. Slide. So health education is one of the major program. It's included students, youth in school or out of school, women, and also risky behavior and general populations. But it's not easy for Indonesia because Indonesia is a large country with a big population, 230 million population with millions of islands, right? And also around 300 local language. Although almost all of Indonesian could speak Indonesia, but in some area local language is very important, and it's not easy to give information to all the population in Indonesia. And also religion and culture, so one of the challenges, and I must say funding, because 70% of HIV control program in Indonesia, 70% the funding is coming from foreign funds, only 30% from our national funds. About prevention, we already discussed about behavioral prevention, biological prevention, and structural change. And for behavioral prevention, we just make a survey last year, and the result is not so encouraging because we found that not yet significant changes in behavioral prevention, although we are already doing some efforts. Slide. Yeah, this is the result of last survey. Slide. And biological prevention, I mentioned again that we still have a low condom use. Harm reductions is still in early phase because we still have different perception about harm reduction, especially needle exchange program. So the progress of this program is still not as we expected. Male circumcision, because most of our population are Muslim, is very common, and antiretroviral coverage is still low. Antiretroviral, for the first line of antiretroviral, is funded by government. But for the second line, which is not so many, because less of our 5% of our people living with HIV got the second line, is funding by Global Fund. But Global Fund also usually complement the funding if the government fund is not enough. We have also international agencies who help us, but due to increasing needs, we still have a problem with the sustainability of the antiretroviral in our country. Slide. There's a study in our hospital about adherence, 1 year adherence of antiretroviral among people who use that is around 80%. Slide. And the challenges is compared with our colleagues in another ASEAN countries. In government service, only antiretroviral is free. Lab tests like serological tests for HIV or CD4 mostly used by the people who living with HIV. Slide. Now about the empowerment, there's some program usually by NGO to increase the family income of a family who one or more of the member are infected by HIV. By doing a small-scale business like selling food or other kind of small-scale business. Our national capacity, the government role is actually the commitment is there, but it should be increased. I must say again that we are very depending on foreign fund. 70% of our control program, HIV control program, is from foreign countries. So it's not easy to us to increase our national capacity in short term because dependency to foreign fund is very high. but we still have hope for the future, because we have our national strategy. It's by our national AIDS commissions, and in some study there is increasing awareness among the public, especially in big cities, and there are collaborations and networking in the country, also between countries, especially among ASEAN countries. So we hope that in 2020 we are in the lowest line, that is there will be in 2020 there will be around 600,000, not 1.8 million HIV cases. Yeah, thank you.
Okay, thank you for all the speakers. Now I would like to invite questions from all the sides. I will start with the Group A. We have University of Diponegoro, we have University of Airlangga, and we have University of Sumatra Utara. Diponegoro, do you have questions? Please state to whom the question is directed.
Okay.
Okay.
Thank you. My name is Suratman. I'm interested with scenario of HIV infection in Indonesia in accordance with your slide. Scenario 80% outreach to risky behavior 2010 mentioned that the percentage of condom use in each high-risk sexual intercourse to be 60% to 70%. How to realize it? Thank you.
Airlangga, the University of Airlangga, do you have questions? Airlangga? Okay, we have no response from Airlangga. Then I will move to University of. Oh, okay. University of Sarawak. Sarawak side, do you have a question?
No question, thank you.
Okay, thank you. University of Sumatra Utara. Hello? No response. Okay.
Yeah, this not an easy job to increase the coverage of risky behavior group 80% and the effectivity like condom use to 60 to 70%, because until now it's around 30% in some area. Especially for this condom use, actually there is a meeting in Papua at that time. We call it, there is a commitment from Sentani. All the governor of Indonesia present there, and they have a commitment to increase the condom use in their population in each province. But the challenges are so many, because this not only the problem of availability of condom or access to the condom, but there are also the problem of cultural and religious aspect. So 2010 is only 1 year ahead. We still hope that we can achieve the target, but we must work together, government, NGO, and also our friends from international agencies to achieve the target. It's not easy.
Okay, thank you. Let me move to the second groups. We start with Kuala Lumpur. Kuala Lumpur, Marash, you have.
Yes, I have a question. Thank you. First is I would like to know, you mentioned that one of the method of increasing awareness in AIDS is by having health education. I would like to know health education to school children. How young would you aim for the age group, whereby they understand the impact of AIDS? Question 2 is that I know that the laboratory test is not free for patients in Indonesia taking the medication. Therefore, how would you know when to start and how to monitor the effect of the treatment? The third question is that you have proposed the use of condoms on a wider scale. I would like to know, are all condoms as effective? Is there a standard to ensure that it is effective, as in, whether some of them are not, how would I say, the standard is not up to the mark, that sort of thing. Thank you.
Okay. Remember, we have 3 other speakers from 3 other countries. So your question is from Indonesia. Let me move to, if we have time, I would like to ask other speakers to comment on questions also. Let's move to University of Gajah Mada. Gajah Mada, you have questions for the 4 speakers? Gajah Mada, are you with us?
Yes.
Okay.
I have a question for the Malaysian person.
Okay.
It is very interesting that the IDU numbers in HIV/AIDS in Malaysia is decreasing. As we know that for almost every country has the same programs, but how can in Malaysia decrease in IDU numbers? Thank you.
Okay. Before we give the time to Prof. Samson, I would like to invite University Udayana. Udayana, do you have a question? A question or 2 questions, maybe?
Only
no?
1 question.
Okay, please.
I've got a question for Dr. Karina Razali from Malaysia. It is really interesting to see that Malaysia has done surveillance for antenatal mothers, and my question is how Malaysia do that. Is it compulsory for all mothers or voluntary, and is it done only in the government antenatal clinics or also include private clinics? Thank you.
Okay, Karina, do you have 2 questions? Please.
Sorry, I'll answer
okay.
the second question first. On the antenatal mothers screening, the reason it can be done easily is because the government healthcare service has a very good geographical regional coverage. There's something called the Klinik Kesihatan Desa, which is a rural healthcare service. So at least every rural villages will have at least 1 small clinic, and these are managed at the federal level from the Ministry of Health. So screening of HIV is done for pregnant mothers who come in for antenatal services, and this is done mandatory in terms of but confidential and anonymous, of course. And through this is how we can get a high coverage. Among the private sector, it's not mandatory, so it's not to say that it is not done, but we don't know the coverage. But I would say a majority, probably about 80% of the population, would go to government clinics for antenatal checks anyway. In terms of the first question, it's basically an interesting question in terms of how come our number of reported cases among IDUs is decreasing. Interesting, because we are asking exactly the same question. We also don't really know the answer for now. I can provide some theories. One, probably a personal theory, would be that so far our surveillance of the reported cases among IDUs has been institutional based. It's been done at prisons and at rehab centers, and it is not community based. So with the prisons and rehab centers, we have a lot of relapse cases, and it's a pool of surveyed population. So it is possible that we have already tested all of them, so we don't have new people to test. It's only the new injecting drug users that come into the services that we test now. so that we have already saturated the pool of IDUs to be tested. But we don't know the level of HIV among the IDUs in the population, the hidden population. So that's possibly it. One argument is maybe it is an impact of the harm reduction with the methadone maintenance therapy and the needle and syringe exchange program. Maybe that helps, but I cannot say that for sure, because it's probably too soon to say there is an impact of those interventions, especially it's not nationwide yet, it's still small scale. And the third, probably most correct from an epidemiological and statistics answer, is that it's not the